One of the other problems that we all always see and very commonly see these days is not just osseointegration, David, but really implants being placed in areas that have type 2 or type 3 deficiencies, where implants are placed towards the lingual, but we end up with soft tissue color issues and a deficiency in the ridge and concavity. And this young lady had implants placed in the lateral incisor region a few years before coming to see us and was very upset. She was in her mid-20s and did not like the color changes that occurred. And these were previously restored implants, and the patient was quite unhappy. And really, in today's cases, we really just don't see these things happening as much because we really try to factor in the diagnosis of the case from the inception. Is it a type 1 case where we have a great ridge and we can place the implant, thick tissue? Or is it type 2 or type 3 case? In this case, a type 2 with a buccolingual deficiency or thin tissue type patient, we really try to factor in additional grafting at the time of surgery. And if this was done, maybe this wouldn't be what we would find in a case like this.
What do you think actually was the problem in that case?
Poor diagnosis, maybe dealing with a type 2 case as a type 1 case. And what we did in this case really is try to reconstitute the thickness of the tissue to mask the underlying color of the implant and abutment utilizing connective tissue. And today, we would probably utilize, at least for me around implants, using more tunneling approaches and really doing that so we don't have to, as Dennis mentioned earlier, worry about lifting the interdental soft tissue here. Very important, especially around previously placed implants. You don't want to lose the interdental tissue and raise a large flap. So doing this in a tunnel approach, I'd probably enter this today from the distal to canine and tunnel across with maybe a dermal graft, dermal tissue. We wouldn't even have to use autogenous tissue. You can see here this was done with autogenous tissue, but again, able to build out the contours of the ridge utilizing tissue taken from the tuberosity, thicker, denser, more fibrotic tissue, something that you actually taught me when I first came to the office here in Atlanta some 18 years ago.
Long time. In this case, how about doing a vertical tunnel? Have you done that?
That's another option.
Vertical and kind of funneling it out a little?
David, what David has shown me to do over the last few years is that you can go in here with these beaver blades or ophthalmological blades going into the sulcus, not raising the papilla, not coming in from the horizontal approach, but actually going in vertically underneath the sulcus with a sharp dissection with a microsurgical blade and going up beyond the mucogingival junction, creating your tunnel, and then slipping the tissue in on the facial aspect. And that's another option. Obviously, a lot of different options today, using that technique, microsurgical, utilizing acellular tissue rather than autogenous tissue. And as Dennis showed earlier, the thicker tissue, obviously I agree with Dennis, if you're going to use acellular tissue, no reason to use the material. What we were able to do here is David was then able to treat the case, not only surgically with tissue grafting to reconstitute the thickness of the ridge, but utilizing Procera copings, and then redoing this with a new all-ceramic crown. So a combination here, David, the ability to, since color was such an importance in this patient, really what we did is deal with this in two ways, both surgically and prosthetically. Thickening the tissue, as you see on the right slide, by at least 2 millimeters. We know this from Ronald Young's work. And then also dealing with it from the ceramic side by having a ceramic option as an abutment.
Obviously, the question is, do you need the ceramic abutment over here? And we know from Ronald Young's work that probably 2 millimeters thickness or more makes this non-discernible. But from every other perspective, even when I go to the ceramic restoration, it's kind of nice to have that ceramic abutment. I think the ceramic abutment is really an added bonus to our armamentarium. You can see the change in color. Nice to focus on that if you go back one moment. Is you look at the tissue form vertically. If you were to put this in black and white, there's not a huge difference left and right. This is really a buccolingual and color issue. So you're looking about volume. You add volume of tissue here, which is kind of hard to see in 2 dimensions. And you've obviously dramatically changed the color. And then, of course, that shadowing, which we don't really see in slides.
Absolutely. I think the ability here to have, this patient was asked if any bone grafting or tissue grafting was done at the time of original implant placement, and the parents told us nothing. Nothing else was done, just the insertion of the implant. So obviously, a type 2 case treated as a type 1 case was the real mistake here. We had osseointegration, we had teeth in function, but you can see that but just simply by adding the thickness of the ridge, whether it be with bone or soft tissue, added the aesthetics that was needed. From a restorative standpoint, going from porcelain fused to metal to all zirconium, added the color changes needed and maximized the result of the case.
We've been able to bring them back lingually because we actually had, you added vertical dimension, so I could actually go to a two-piece restoration, meaning I could actually use an angled abutment, which the first one we couldn't. They were just kind of screw-retained restorations at an acute angle.
And as you see, very, very nice result. This is about 2 years post-op. A high lip line case. You can see the color, very difficult to discern these two spinel all ceramic crowns from the adjacent natural teeth. And you can see that this tissue, this dense fibrous tissue, can be maintained over the long haul. So obviously just another option, how to rectify color issues. I think tissue thickness is something that is often neglected in diagnosis, and at least for us, something that we really point out to the patients, at least in the aesthetic zone, is very important. So for us, the components of the aesthetics really come down to our ability to negotiate this fine area, a highly scalloped gingiva, thin and highly scalloped, the most challenging environment. How do we benefit the patient from proper diagnosis and treatment, trying to maintain the harmony and balance of the soft tissue, the labial and the interproximal, doing this and trying to avoid what we see here on the right screen, which is really failure. And failure in many cases, not really technically for us, it really mostly comes down to diagnosis. And is there a formula for implant aesthetics? I think for us, and sort of summarizing this lecture this evening, is I think that for us there is, and it's really an algorithm for us, an X, Y, and Z equals a question mark, and the X would be the thickness of the tissue. See here, we have to measure that thickness about 3 millimeters below the gingival margin. The Y would be to evaluate the location and thickness of the labial bone. And of course the Z would be the location and the presence of the interproximal bone on the adjacent natural teeth.
So when you're talking about measuring on X, you're talking about vertically as well as the thickness of the tissue. You measure that.
We measure the thickness here of the tissue, the location and presence of the labial bone either through bone sounding or through CT scan technology. And of course, the interproximal bone can be measured CT scan or bone sounding on the adjacent teeth, which is shown very beautifully diagrammatically by Dennis and Stephen. So if we want to avoid these types of problems, we need to understand the diagnosis. We need to appreciate the surgical necessity for augmentation, either before or during the time of surgery. And something that we're very, very excited about is working on some of these projects with Dennis and Stephen in the future with immediate extraction in the aesthetic zone. One of the things that I'm very happy to be a part of, and Dennis was nice enough to come and lecture at last year, again, the Partners in Synergy meeting with myself and Mike Picos, which will be in Orlando, Florida at the Ritz-Carlton, June 9th through the 12th, 2011. And you can find more information about this from Allison Teedy at the learnandpicosinstitute.com. Once again, for us, it's all about making successful clinical decisions. Success is not by accident, but we feel by design. I think what you've seen tonight from both ourselves, Stephen and Dennis, was really how to avoid problems, how to properly sequence and manage treatment planning, and then when you get in trouble, the role of soft tissue augmentation to fix those problems. I look forward to the question and answer session, and I'd like to thank you all for your time with us here in Dental XP tonight, which was just a world-class opportunity to be with some of the best colleagues in all of dentistry. Thank you very, very much.